which is bumper to bumper.
You are welcome once more. So we started a discussion yesterday on validity, reliability, and diagnostic tests. Yesterday we went through reliability. I want to quickly, within 10 minutes, to actually go through yesterday's slide without doing the practice what we did yesterday. Professor Sunday is here. I think that's the only person that was not on board yesterday. So we started that we need to carry out reliability and validity of any instrument that we use for capturing data. And validity means the success of method in proving or assessing what is said to prove. If you measure, when we talk about method or instrument, it can be questionnaire, it can be even physical instrument, it can be laboratory equipment. You know, somebody was asking a question yesterday. We need to differentiate between two: instrument, equipment, and questionnaire. Just say, okay, tool and instrument, they are used interchangeably. So the tool or equipment or instrument are broad terms. So it can be questionnaire, it can be equipment, because whatever you use to capture data, even a method also, like a Glasgow coma scale scoring system, even assessment of what do I call it, finger clubbing. They are you can call them two because they are two, even though you may not be physically, they are two for capturing, because anything you use to capture data I consider as two. And when you talk about method is broader. Even the whole research is a method, because at the end of the day, we may talk about the validity of your research, the whole of the research. What is the validity of the finding? So when we talk about validity, what you said to measure, you may apply it directly even to the whole research or part of the instrument you are using. To what extent does it measure what it tends to measure? And the reliability refers to the consistency of the data stemming from the use of a particular research method. How consistent? If you repeat it, will it give the same result under the same condition? Or if other person is using the same method under the same condition, are you getting the same similar result? That is the reliability. And we created a picture, mental picture of it yesterday. You can use that to illustrate, which we did yesterday. You can see the left side of the slide, you see picture of 3 dartboard. Both the one up and down, they are the same. It's just like the one up is actually showing the arrow, that somebody is throwing arrow. So the first one, we said that from there, if you want to use darts, throwing darts as a method, to illustrate validity and reliability, the center of the dart is the validity. That is, you aim at the center, and if you can hit the center, that shows that you are valid. That is valid. That is, because validity is the degree to which you can do the instrument prove or measure what is meant to measure. So if you throw the dart and hit the center, it is considered to be valid. But if it doesn't hit the center, it's not valid. Then if you are able to hit a particular play consistently, it's reliable, you are reliable, or whether you or the dart, it's reliable. So if you look at the first one, you can say that there is no validity, non-reliable, not valid, because the arrow is not hitting the center, and it's not even, it's just haphazardly just hitting the periphery. That shows that it's neither reliable nor valid. The second one is, you can see that the arrow is hitting the particular place consistently. It shows that it's reliable, but it's not valid because it's not hitting the center. So the third one hits the center and hits the center consistently. It's both valid and reliable. And in the picture, you see the red board down. Now, you see there's another option that may come up. Is it possible for it to be valid but not reliable? And that is why the right side of the slide is showing similar thing but with a fourth picture. If you look at 1, 2, 3, 4, the number 3 is different. So number 1, 2, 3, number 1, 2, 1, 2, and 4 are similar to what we have shown on the left side. But the number 3, you will see that it says fairly valid but not very reliable. So it's able to hit the center, but not consistently. Some are on the center, some are outside the center. So the question arises now comes in. Is it possible for a method to be valid without being reliable? They may know it's food for thought, but many experts have agreed that reliability is a condition. It's a necessary condition, but not sufficient for validity. So a method cannot be valid without it being reliable. Okay. Because if, for example, now if you are throwing the dart now, and sometimes you hit the center, sometimes you hit the periphery, it's not reliable, but we say it's valid. It becomes gambling. The method sometimes measure what it's supposed to measure. Sometimes it doesn't measure what it's supposed to measure because it's not valid, it's not reliable. So will you consider it a valid method? It becomes a gambling method. So no, you cannot consider it to be valid. So a method, an instrument or a method cannot be valid unless it's first reliable. So reliability is a necessary condition for validity, but it's not sufficient. So that shows that it's possible for a method, an instrument to be reliable, but it's not valid. The other way around is not possible. Now, I think that one has captured everything. We also talk about practicability and backward effect. How practicable the method can be reliable, valid, but it's not practicable in the setting when it comes to economy, effort, and money. Sometimes we also talk about backward effect, which is the influence of testing on teaching and learning. So sometimes the method can be so boring, may not be interesting, even for people to learn. In that case, it will affect the applicability also. We may not be interested in it. But if it is exciting, it's very interesting. So that one will enhance people using it, especially if it is valid and reliable. So we also talk about a different type of validity and reliability yesterday. And there are different types, but all those types can be grouped under the 4. Under the 4, you are seeing yellow, yellow color on the slide. So it can be test, retest, and can be agreement, scoring agreement, or equivalent, or parallel, or alternative form. You can call it equivalent form, or parallel form, or alternative form, or it can be internal consistency. So not all of them are mutual, they are not all mutually exclusive. Some are, because whichever method you use among the 4 depends on the situation, setting. There are some settings that warrant a particular method. But internal consistency on its own, sometimes there may be overlap because you can do test, retest, and do internal consistency at the same time, because internal consistency is only applicable when the instrument has many parts in it. Like for a questionnaire, it has many parts that make the composite. So because internal consistency look at whether these different parts are saying the same thing. Are they pointing towards the same direction? That is what internal consistency is looking at. So, and whether the method you use also depends on the variable you are measuring. If the variable is categorical, if it is quantitative. So when for categorical variable, most of the time, and it's only one, two. Maybe if it's only one, because if it's categorical also, it's rank, and there are many, it's rank. When I say it's rank, that is, it's ordinal. So if there are many under, you can now have a composite scoring system. Even though originally each of the item is categorical, each of the item is ordinal. Then because we have many items, you can add them together, and it will give you a quantitative outcome. which you can now use. You can even do the internal consistency also. You can do test, retest, reliability with it. But if it is only maybe just 1, 2, and its rank is categorical, so you cannot do that. You go for agreement, and this agreement we have is believed that because the agreement scoring, I said something yesterday. There is this notion that the investigator, the person administering the tool, really has influence in the situation when you rate, like you rate something. When you are rating something, the scoring depends on your rating. Like for finger clubbing now, if you are to do, there is a guideline. But if different people examine the same finger, they can come with slightly different results, even using the same guideline. Because you can say, somebody can say, the person has grade 3, and that person may score grade 4, so or grade 2. So it depends on the rating. So when the system depends on the rating, the judgment, the questionnaire now is not like that. If it is ordinary questionnaire, it's just for the person to administer the questionnaire, for the person that is answering to answer, to tick. But this one now, this person is assessing. So the assessment now, the result depends on the judgment of the assessor. So in that case, you have to, if there are 2 ways to read. You want to validate, you can validate, you can have 2 people assessing the same set of people and now compare the 2 results. Or 1 person assessing on 2 occasions, the same set of people on 2 occasions. That would be intra-rater, when 1 person assess on 2 occasions to see if there's consistency in the outcome. But if you use 2, more than 1, can be 2, can be 3, that would be inter-rater. So there are different methods. So the method you now use now depends on the situation. And there are different forms of each of them, like for internal consistency, where we have come out that the Kronberg alpha coefficient is the best because it was an improvement. I don't know, somebody is making noise. Let's try. Baba Ghana, you are the one making noise. Yeah. Yeah.
Thank you, sir. I've muted myself.
Yes, mute yourself, yeah. So who is using Galaxy G8? Who is Galaxy? Who is using Galaxy?
Is it really Galaxy?
Galaxy. Okay, is the Dr. Ikobo?
I'm in the car.
No problem.
So
don't worry.
I will soon get to where I'm
Okay, no problem.
Change it to your name.
Okay.
Don't worry. I've known him now. He's the one. So, because you have to be.
He's in Bonny Ireland.
You have to be security conscious. Okay. Thank you. I think we'll move ahead. We are not going to waste much time because we dwell much on it yesterday. And reliability coefficient, intelligent people now came with how to quantify reliability. And actually, the reliability coefficient is just a form of correlation coefficient. The only thing, though, in some situations, when we measure reliability, is correlation we calculate between 2 sets of score. It's correlation directly. Then, but in this case, there's no way the correlation can be negative. It's always positive because of the nature. Correlation can be negative, but for reliability, it will always be positive. And the reliability coefficient some people develop, there is a form of correlation like kappa, like Kronberg alpha. Those are special forms they develop. And the value is from 0 to 1. So we have talked about these different forms. And yesterday, we have an example. We run an example of test, retest, reliability using, you take measurement 2 times, you administer a questionnaire, two times on the same set of people, and you correlate the result. So we calculated the correlation yesterday. We also did parallel form.
I have the password for.
So then for parallel form also, we did the same thing. We administer different to, parallel form and different to, similar to. Yeah, it's doing the same thing. So even though I don't like to talk about exam question, but you can use it as an example for people to conceptualize. You remember NECO and WAEC. If the same syllabus, you believe to be the same exam. If they are, you want to know if there is, you may want to see the reliability if taking NECO is the same thing as taking WAEC. No, because any of the exam goes, stand for what they believe the certificate should stand for. Then the West African National Exam, postgraduate. So it's the same thing because they are parallel form. So in that case, you can administer the same two to the same set of people and now compare the scoring. That will be parallel form. And if it is a quantitative variable, you just do the correlation. If it's categorical, of course, you don't do correlation. You can, if it's categorical, you can even use we can as well use the agreement also to rate it, or well, it depends. If it's category, if it's order, the agreement. But if it's not order, just use chi-square to cross-tabulate and see if there's any difference. But most time, if there's scoring involved in a mark, you can correlate. So we did that yesterday also. Then for the agreement, we did kappa. We had an example of two dentists rating teeth surface of teeth, and we do current kappa. We explain the formula and we also run it with SPSS. And this is the example. Then internal consistency, Kroger Alpha. We had an example of 4 questionnaire. We also have an example of 25 questionnaire, item 2 yesterday. But we used the 4 to illustrate the logic behind it. And the logic behind it, as I've said, is that the Chromback Alpha is an improvement on the work some people did, like people that invented half, split half. Then we have the Kudaroda-Richardson method, and we have Gottman method, different method. But the Chromback Alpha is the peak, because what a split half did was to divide the 2 into 2. That is, if the 2 have maybe 10 items, now split them into 2. If 20, split them into 2, whichever way. So you now correlate the score, because the logic behind the internal consistency is that if all the 2 should be pointing at the same thing. For example, if I want to measure happiness, if I'm happy and you ask a question, all the questions, if there are 10 question items, the correct item in that 2 that is measuring happiness. If I'm happy, you ask me, if I score, I should be able to score on the high side. If it's on the scale of 1 to 5, for example. If the first question, one of the question, I score 4. In all those other questions, I should be scoring around that 4, 5, 3, be on the happy side, if I'm actually happy. So if one score high, you should score in one, you should score high in the other. If the person is not happy, you should score low. If you score low in one, you should score low. If you score 1 or 2, you should be scoring around that in order. If actually they are pointing at the same thing. Because if I'm happy, the first question you ask me, I should score high showing I'm happy. The other one should be, even if I'm not getting the same score, it should be towards that side. But if it is half side, you score high in one, we call low in one, we call medium. That shows that thing is not measuring the same thing. Maybe it's measuring all those items are not going in the same direction. That is what we call internal consistency. And when they split up, but when you use split up, that is the logic. When you split into 2, if all of them should be, if the result of all of them should correlate. So if you split into half, half should correlate with the other half. But there are different ways you can split something to half. Different way. If they have 10 questions, there are different. You can move number 1 to 5, number 6 to 10, or even number. Odd number, or alphabetically just select alphabetically. But there are different ways. So you have to now look at how many ways can you pair. And now come to combination now. So the more the number of items, the more the number of ways you can pair. You can pair the different question there. So that was how different those other people started improving tried to circumvent the problem until Kronbach now came with the logic, his own logic, correlate each item with others, except one by one. When you correlate each item with other, the score of one item with the other, the addition of other item. So we do it for all the items and I calculate the average, and that is what it did. And this is the formula here. It's the N over NC, N bar C, it's actually bar C, N bar C all over V bar V plus N minus 1 by C. So N here is the number of items. If there are 4 questions, then N will be 4. That's capital N. C bar C is the average inter-rater covariance. We discussed that yesterday. And we have discussed covariance. It's very simple because when we discuss correlation, because correlation is the standardized covariance. The standardized covariance. So why V is the variance, is the average of the variance. So we did that yesterday. We are not going to with this example, and we run the same. All the example we did, we calculate them with hand, and we also run with expression. We get the same result, exactly the same. So I think that's just an overview of what we discussed yesterday. We may not be able to go through, begin to run everything we did yesterday. Now, today we'll look at validity and lay a hand on some calculation. We have already established the fact that validity is the degree to which a system, a method, or an instrument, or a tool measure what it's supposed to measure. Now, there are different approaches because they call it types. When the people that came with the concept, the psychologists, the Association of Psychologists in America one time, they form a committee that they consider a committee to look into issue of validity, how to validate psychometric instrument, and they were the first to coin the word construct. So when in that meeting, the report of the committee was not actually to classify to say this is the type of validity. They actually approaches to validity. But of course, you just say type of validity. So whichever way we can look at it as approaches to validity or type of validity. And this one, you can in some other write-up, you can still see different classification, but they are not too far from what we have here. In fact, you can even see, you may see many classification that is not as elaborate as what we have. You see stuff. And the reason is that people just, if there's a method, one method may be a subset of another, they give it another name. Now, approaches. Let's just consider as approaches. How do we validate instrument or a tool? The first approach, the simplest, as we are looking at it now, it appears that it's from the simplest to most complex approach. Now, phase validity, a situation where you have a tool, and I think we discussed that yesterday, but still talk much about it. You have a tool, and you just want to know to what extent these two measure, the content, the items in the tool. To what extent does he address the concept or what you are trying to measure? So in that case, it's just an expert. You give to an expert, person who is an expert, who is experienced in that subject matter. We look into it and look at the tool and say, oh, yes, the tool, yes, it is addressing this issue. It's not addressing something else. Just like somebody brought maybe happiness, and there are some item there that is not pointing at happiness. It's something else. So an expert says, well, this one is not talking about happiness. So that's what faith validity is all about. And it's subjective because it is believed that you give to experts. So that's why if you give a particular tool to different experts in the same field, they may not come with the same conclusion. Because they are different experts, they may have some area of differences. So the objectivity there is quite low. Then the content validity is similar, but it's different. They are close in the sense that it's the same expert also you give to. The content now look at the objective, the scope of the tool to see that as it cover the whole scope of the subject matter. For example, now if you have an objective and you design a tool, and the expert will tell you, so this tool does not capture this all the different parts of what you want to achieve, or the subject matter. So there are still some areas. So to what extent does it cover the universe, the whole of the universe of the subject matter? That's the content. So both of them is the same, it's subjective. And some people, they classified the two of them as translational validity. I don't know why. Maybe because you need the translation of the expert, because the expert is actually translating. You know, when we say translate, it takes the person that understand the language to translate. So it's believed that this expert that know the subject matter are able to see if there's phase and content validity. Now, another approach is the criterion validity. The criterion, when we here now, there's a level of objectivity here. There is something you are comparing your measure, what you want to, the instrument you want to validate. You have a gold standard that you have a criterion you want to compare it with, and that criterion is usually measured by a gold standard. I think this one is easier to even understand for us that are clinicians. Like for example now, if you want to make diagnosis like a cervical cancer, you want to validate pap smear. So the gold standard is biopsy. So the criterion that pap smear, what you want to measure if there's any abnormality in the cell, cervical cell. So the criterion you want to compare it with is the change in the cell, change in the cell, mineral dysplasia, whatever you call it. Now, is biopsy that actually confirm that is the gold standard. So most of our diagnosis pathologists that actually provide the gold standard. Even sometimes maybe after the patient is dead, they are able to actually know the right diagnosis. So in criterion validity now, there's a gold standard, there's a criterion which you want to compare your tool with, and that criterion is measured by a gold standard. Now, there are different, still under that approach now, we have many, sub approaches now. Different way you can achieve that. It's possible for you to measure, to take data on what you are measuring now, and also capture the data of the gold standard, or measure the criterion at the same time. For example, now, the example of pap smear I talk about, you want to validate pap smear, you can take the sample and for pap smear and the sample of the biopsy at the same time from the same patient, and you wait for the result. When the result comes out, you compare the result for all those people, you compare them. That is concurrent validity. If in the name, as the name implies, concurrent. At the same time, you're able to capture the data of the what you are measuring and that of the gold standard at the same time, concurrently. In some situations, it's not possible for you to capture the data at the same time, because what you are measuring is actually predictive, in the sense that what can actually confirm that criterion that can confirm what you are measuring will happen in future. For example, JAM is to prepare students for university admission, believing that if you pass the JAM, that person is capable to be an undergraduate, to study in the university. But Of course, the result of JAM is not just that you pass or you fail. There's a grading also, and that is why you have cut-off point. That's why some courses are more competitive or whatever. Well, there are many factors under that. Sometimes some courses are more competitive because many people apply for the courses. The general knows there are some that will be more competitive, maybe more difficult, maybe more time demanding, and many other things. So you may need a higher level of IQ to do a particular course. So now, the essence of the JAM or the secondary exam is to prepare, to note who are those good ones, who are the best, the average, the distinction, the average, and all those stuff. But how, to what extent are this exam measuring those things? You cannot know until the outcome. If after those people that have passed the JAM or they have been admitted to the university, so their grade in the university now will now determine maybe those people that score high in JAM, are they the one having higher grade? Or it may even be university, the GP also university. Because the essence of it is that when you finish, you are a professional, you come out as a professional. You can now work in a particular field. Just like say you have been admitted to the bachelor degree into, you are admitted into. Now, why those people are working now? Their impact in the industry, the impact they make in the industry, I know those people that are making impact, they're the ones that actually have higher grade. So the criterion is in the future. So for the JAM now, the criterion will be the GP. For the GP itself, the criterion will be the performance in the industry, in the profession. So that we call it predictive. They start predictive validity. So to what extent can your instrument predict the reason for having that instrument? So the reason for having that instrument, like the reason for JAM, you cannot get the output immediately until you have already committed yourself. You already faced some people and passed some people. That is when it is after that you be able to measure the criteria. Now we also have predictive validity. I think an example, for example, you say that myocardial infection. Example, they usually give myocardial infarction and creatinine kinase. It's when somebody have it's after the infarction that you measure that enzyme in the blood. So that one now, what is measuring what now? Because the creatinine kinase is the one that is trying to check if there is myocardial infarction. But the myocardial infarction will have happened before you measure the creatinine kinase. It's different from predictive because the criterion now is the myocardial infarction. But what you use, the more like a marker, is the creatinine kinase. So it goes back. So unlike the predictive, the criterion is in the future. Here the criterion is before, what you are measuring is after the criterion. So just the opposite of predictive. Now, those are approaches. Now the last one, which is the most controversial, the most difficult to measure, is construct validity. Construct validity, what is a construct? Construct is a latent variable. Well, they say, even some people say it's not even a variable, but you can just conjure a variable to measure a construct, more like a concept, something that is hidden. You remember, they are latent, they are more like concepts. Yeah, we call them latent variable. They say they're not variable. So it's latent because you cannot see it, you cannot pass, you cannot easily detect it. You can only represent them by what you think are features or outcome of the construct. For example, the psychiatrists that measure, that diagnose depression, they will ask questions. Is there any time you contemplate committing suicide? How many times in a week did you anybody you fight with people, or do you feel that you are neglected, nobody love you? You know, all sort of question. Anytime you are afraid of the future or afraid of, so after asking those questions, you now say, oh, this person have bipolar depression. So bipolar depression is a construct because the is psychological is a concept now that you cannot see, but you can only infer them, infer it with some things attributes. You're able to attribute something to the person. So all those things are the variables now you are mentioning. But the construct itself is hidden. So construct validity, when you are trying to measure something like quality of life, it's a construct also, happiness and many things. The construct. How are you sure that even the question you are asking is able to measure? You know, you notice something, most of the variable we do when we talk about validity in clinical medicine now, apart from psychiatry, most of them, most of the variable we measure, all those laboratories is under criterion validity. But when it now come to the construct, those you cannot even measure in the laboratory. So that is all those concepts like the quality of life, like social support, many things. So for you to validate that type of instrument, you'll be talking more of construct validity. Now, the approaches, Dr. Ikobo, you have to move. So some approaches to the construct validity. There are two, can I say two major approaches? You can look at internal constructs and external construct. And we are still coming to another dimension of validity, which is external and internal validity. This one is different from the external validity and internal validity. We discussed that. If you look at the slide, down, you see it. But this one, the construct, internal and external. And the logic behind the classification like that is because the construct is difficult to measure. Sometimes people try to relate the construct with other similar constructs. So when you are trying to relate the construct with other similar constructs, that is external, because though it's similar construct, but it's different from what you are measuring. So comparing the construct with others, that would be the external construct validity. Because if similar construct, if the people they are able to, the participants are able to score high, and the score in similar construct is the same thing with what you are trying to validate, you can say, okay, it's valid, because that similar construct, if it has been validated before, and you see that they are similar. If somebody like anxiety and depression, they work together, it means, okay, anybody that score high in any scale that is measuring anxiety may score high in the scale measuring depression. So that one is external, and they call it nomological validity. So sometimes in trying to establish that, you may have many of those similar constructs. It now leads to what we call nomological network. I think we have something like that in our slide here. Now, the internal, that one is restricted to that construct you are measuring. But the way to still do that is that you may look for, okay, though you can see, compare also with the score with similar construct, but here, for nomological, it's a network. There are many of them, many of those similar constructs, you're trying to link them with better. In this case, you may have convergence validity, how you compare the score on the two with a similar, the score on a similar construct, or maybe another instrument that is measuring the same construct. You know, yes, there is another instrument that is measuring the same construct. Like when we talk about quality of life, you see many scales. Quality of life of people living with HIV. you can have many scale, many instruments that is measuring this thing. So if you can compare the two, if you want to now do your own, so you have a tool, you want to validate it, you will now bring another similar tool that is measuring the same thing and administer it. If they correlate very well, that's convergent. But if you have another construct that is opposite, you can have another construct that is like direct opposite of the construct you are measuring. So if you apply the two, you expect them to not to correlate very, the correlation to be very low. So in that case, that is discriminant. And you also have a situation if you have the construct, you have already know a group, a particular group, which you know their validity. You have already they have validated the two among this group, and is valid among the group. Similar group, you can now compare your own group. Like for example, now that's the example we have here. You may have maybe people living with HIV, they have support, they are supporting them, they have social support. There's a social support group supporting them, and you want to look at their similar, maybe the support social domain of quality of life. So if you have other group that have you know that you have used the tool on, you can compare the score on that group with another group, similar group, social group. In that case, you are trying to see, they call it non-group validity. So if you also do it, compare the group with a group that is not receiving support, you expect them to differ, but the score should differ. Why for the group that are similar, the score should be the same. They should not differ. It may not be actually the same, but you know, have statistically significant difference. I think that's just the overview. Then we may be specific to a particular time sample and context. Now, instead of looking at the two now, sometimes we may look at the whole study or the whole setting. You know, when we talk about validity, it's unlike reliability, because reliability, most of the time, pin down on the instrument you are using. The validity may go beyond the instrument, even the whole study. May be talking of the validity of the whole study. So internal validity, where you look at the finding of your study, if it is valid, is it true for the group you even study? I don't know if this lady is around, Dr. Odirishi, Dr. Raymond, has she come? She's not here. So because she has a tool, she developed a nomogram for peak expiratory flow rate. So we were talking of, and the nomogram was through regression. Created a model with regression and developed the nomogram. Now, she was talking of validating the nomogram. If you want to validate it, you can do external validity in the sense that you can do both internal and external validity. You know how good is your model. We talk about it when we're talking of regression, both linear and logistic. We talk about it. If you apply some of the people, like for internal validity now, when you develop, maybe you create a model through regression, and you cannot substitute, cannot put in the value of some independent variable and see if it's able to predict the value in your data set. That's internal validity. You want to see even how true, even that model for that group. That's the form of internal validity. But if you want to do the external validity, bring people outside. From outside, it's not somebody now, like for our own now, peak expiratory flow rate. You can go and do peak expiratory flow rate apart from the one you use in your study, and measure their height, weight, know their sex and other all those other factors, other independent variables, and now fit into that equation to model to see if they are able to predict the peak expiratory flow rate. That would be external validity. That is, to what extent is it finding true for even the people outside the research setting? And the people outside the research setting, there are two levels of it. The immediate research setting, that's the population. Population facility, population validity. But maybe in another social context, like now you did a study and now try to validate in Ghana, because Ghana is a similar ecological setting like Nigeria, but it's not the same population. They're not the same. So that would be population validity and ecological validity. So both population and ecological validity are a form of external validity. So you see, knowing how to carry out validity is not a function of statistical skill per se. It's a function of understanding what the validity means, and well, if you need be, you need to employ some statistic, you now employ the statistic. If you look at it, most of it, the reliability is either you do, and even validity, either you do correlation. You see, correlation is the most, is the commonest effect measure that comes out when it comes to reliability and validity, correlation, but not all. Even the other correlation measure of correlation coefficient, that is different from, they are actually a form of reliability coefficient that we use, like Kronbach alpha, we discussed, like current kappa. All of them, they are a form of a correlation. And when you come to reliability also, validity rather, is similar, but there are some other things you do. As you see, sometimes you can even do an over and do t-test for validity. So I think I don't know if there's any, I talked for so long. Any question before we proceed to example and run it? Any question?
We are fine. We are fine.
One person that says it's fine. So somebody is speaking for all of us. If you have question,
it's okay.
Somebody
a lot of information actually.
Okay, that's fine.
I'll come from you. But to really imbibe everything and flow with your examples, it will take reading and rereading and trying to listen to this tape again. Though those of us in clinical medicine, it may be tough for us to start swallowing the discriminant and all this type of things. But it's okay. It's all right, no problem. It's be fine. It'll be fine.
No problem. Okay, that's great.
No, your explanations are straightforward and they are easy to follow. I'm just looking at so many concepts, so many definitions, and
yes,
I mean, some of those things that you.
If you take it one by one, they are very easy. If you look at it, like what?
Yes, maybe when you start doing, what I think is if you start doing some research work where you have to bring some of these concepts in, then it will stick better.
Exactly, yes, exactly. That's
the practicality of it.
Yes, that's the practicality. Because if you look at it, actually, once just like what I said, validity, reliability is not based on bogus statistical knowledge. It's not based on, it's just simple. Yeah. It's with the statistic you know, simple statistic you know, and not understand what to do. You know, somebody on Thursday was saying that I can't understand anything in what you are doing. And what the person was not following was that the correlation we talk about, we're using here, we have discussed correlation extensively, but the person was not, if the person was not, because this class is not for me to be explaining correlation coefficient. It's just for me to say that we use correlation coefficient. So we have discussed correlation, covariant origin of correlation as a standardized covariant, all those things. We have discussed them. Anybody that wants to learn that should go and listen to watch the video. You'll be able to understand the concept of correlation. But it's more like application now. Somebody say, can we explain the concurrent? Yes, concurrent is even one of the simplest to swallow here, because what he's saying is that You want to validate an instrument. You want to see if the instrument, and that this instrument can even be weighing scale. It can be, I give an example now, diagnosis of cervical cancer. It may be other form of diagnosis. You know, like all these people that do even ultrasound. Okay, somebody that is using ultrasound to somebody, the people that do arterial angiography, they put a catheter into the into the blood vessel and compare with ultrasound. You know that the angiography now is invasive, highly invasive, and can something like Doppler ultrasound replace it? Where you just put probe outside down and using sound to detect. So you may want to validate that method using ultrasonography. You want to validate it. The gold standard will be angiography. So if you want to validate it now, that means that you have to, if you have maybe 50 people you want to use as your sample, your patient, you have to do both ultrasound and angiography for them. That's why the word concurrent comes in. That is, because what you are validating is ultrasonography. Angiography is the criterion, the gold standard, because the one that actually measure what you are measuring. You want to see if ultrasound can, to what extent can ultrasound do the same. The ultrasound cannot do the same exactly, but will it be close to it? So the ultrasonography is the test you want to, method you want to, instrument you want to validate. The angiography will be the gold standard. You have to do, for you to validate it, you must do both ultrasound and angiography for all those people involved. It is when you are validated, oh, is good, it's the same. Then you cannot begin to do only the ultrasound for people and forget the angiography that is very invasive and more difficult, whatever. So for the fact that both, you have to do both the take data for both the instrument with the instrument you are validating and the gold standard at the same time from the people at the same time. That's why it's concurrent. Unlike predictive, where what you are validating is now, but what can serve as the criterion as the gold standard is in future. How do we know? Example, there is somebody that has scored high in JAM. It's better, it's all that scored 300. It's better than the person that scored 150. How do we know? In Nigeria, you can see it's more brilliant. But nobody is sure of that because the system, examination is not even a true test of knowledge. The same exam, if you do take the same exam now, you go the next week and sit down for the same exam. The person that failed very well may pass. The person that passed very well may fail again. So the examination itself. So how do we know? So what is the examination for? They say it's for getting good people to enter university. Okay. When they enter, let's see how good those people that score high and how bad people that they manage to enter. Some people they have to manage, they have to lobby because they score very low to enter. So let's see that you still have to lobby for them to scrape through, or they even become better. So for you to validate, the gold standard now for the entrance exam will be the GP in school. So you can see the gold standard is ahead, is when you are measuring, you are doing the exam, you are capturing data for that instrument. The gold standard, who is making or somebody is making it. The gold standard, you cannot capture data for the gold standard because it has not come. It is in the future. That's why you call it predictive. So your instrument is just predicting. It's predicting what it's supposed to measure. I'm trying to get prof that is making. So it's predicting what it's supposed to measure. And you know that validity is the ability, degree to which the instrument measure what is supposed to measure. So what is supposed to measure can only come in future. Can you see now? That is why it's predictive. Then predictive is the opposite. I think there's a slide, in that on this slide I said a lot of things, but there's many slides that explain some of these things also. Yes. Look at this one, what I just said. The concurrent and predictive. Okay, for example now, Western IQ test of intelligence, then Victoria Super Intelligence test. So both of them, the Victoria Super Intelligence test, that one has been validated. You already say that is the gold standard. So you now administer the two, you want to validate Western IQ test. So you have to administer the same two at the same time. The two tools at the same time. That is concurrent validity. I use clinical example now. This one is a social example or psychological example. Anyway, so psychology is social also. Now, predictive validity, look at it. College entrance test and first year college grade point average. No, that's what I just said. So I remember in my secondary school, when I went to village school. In my village, when in my secondary school, my own primary school was this, where the smallest then it was the most recent. They call it community primary school. Then usually most of the people, young people there. So even average people that finished from that school were relatively young, younger than the others. So when we got to the secondary school, they usually paste results. The entrance, your score. So I now saw because I scored the highest in my school. I scored the highest in my primary school, the entrance exam. When I got to the secondary school, my name was number 11. And because they listed they didn't put according to your score there. In the secondary school, I said, this 10 people must be. So who are these 10 people in front? Even though people were congratulating because to be in one of the 11, the people believe that you must be one of the best to be one of the 11. But and I say, who are these 10 people? But you know that none of the 10 people even finished secondary school. None of the 10 people finished secondary school. You'll be surprised. None of the 10, I'm telling you, finished secondary school. They drop out. They all drop out. And the reason is very simple. All those people they were children of teachers, primary school teachers. All those people, one was a senior girl that they were just pushing. So there were a lot of practices even during the exam. So at the end of the day, it was the performance in the secondary school that validated the entrance exam. So at the end of the day, that was a form of predictive validity. Because by that time, the deal that we done, you get your score, people that score, will score, but nobody will know until future whether these people that score high were better or they are not better. So that is just predictive. Then predictive. I think where okay, there's a place I mentioned. Okay, I will still get there. Predictive. I give an example. If you look at the predictive, the criterion is in the future. The predictive, the criterion is in the past. Like now, you are measuring you try to measure, you are trying to something that you are validating, what do I call it? Instrument or a method for diagnosing myocardial infarction. And the only thing that can help you validate that myocardial infarction or something is creatinine kinase, the enzyme that is released during infarction. So if you know that what you are trying to diagnose is myocardial infarction. No, sorry, what do I call it? What you are trying to validate is, I think it's creatinine kinase. But the gold standard is in the past. You have to make sure the Mercator infraction will have happened for that criteria to be released. Can you see that? So this type of the thing is predicted. So the gold standard is in the past, but what you are trying to validate, the thing that's happened before, what you are trying to validate, instrument you are validating will come. So before Mercator infraction will have happened before you can be before the creatinine kinase will rise. That is the form of. I think even they're producing Mercator based on creatinine kinase and troponin. It's even on the slide. I was looking for it. Look at it. So that's predictive. I think I only found for me. I think we should quickly look at an example. All these talk, I think I've discussed them. The different words, content, criterion, discriminant, what we have on the table, I've discussed them. Any question before we proceed? Any question? Okay, if there's no question.
This is just by way of comment. I mean, okay, going through this now, something just crossed my mind.
Okay, sir.
That if you really want to know whether JAM is a true test of knowledge,
yes,
the performance during undergraduate year or GPAs, I mean, if you have data to correlate the two, that will have probably provided a very important source of information whether this exam should continue or something.
Yes, that's just it. That's just it. That's what we are saying here.
It's just because we don't have this data.
We don't. Yes, we don't have the data. No, it's because we don't bother to collect because the JAM result is there even for many years. Yeah. You can even the result for the school also is there for you to go and collect it for us to do the study. Everything is there, but we know that study consume money. You know, many a time you don't know that all those studies that involve psychological something they consume money more than the one we readily do because it takes a lot of effort. You have to do a lot of training. Like now, as you as physician, as you're in the clinic, you can be collecting your data in the lab. You collect your data in the hospital. But when it comes to this type of thing, you know, for you to capture the data, because we have the secondary data now. You have the data there. You go and extract them. You spend a lot of money because you have to train some people so that they don't extract the wrong thing. You have to spend a lot. It's very costly. So, you know, once we have people that are ready to fund that type of research, it's done. Is it you that you are managing with your salary, with the economy and everything? Will you now go and put your money into, you know, all those stuff? But when we have organizations that are funding that type of thing, you see that the information will be there. And that is what, because our own government, there's no evidence-based decision. We don't take decision based on evidence. That's just it. If the country that takes decision based on evidence, all this JAM, all those Ministry of Education, that's what they should spend money on. How do we even know that this JAM as it is doing the right thing? You know, terrorizing people. So that's just it. So yes, Prof, sir, go on, sir.
Well, just to how will I put it now? I mean, to support what you are saying, and those of us in behavioral sciences, psychiatry is in between biological and social sciences. People look at us as not seeing something or doing something that is real.
Yes.
You know, there is a stigma against social sciences. They do not know that our research in psychiatry is more difficult than those.
It's more difficult. Yeah, it's true. Yes. It's more difficult because it's all those things that are difficult to measure. If you want to come out with something reasonable, you will know if you want to tell lie with statistics. You have to spend a lot of money. You have to do a lot. Okay. Now, let's look at this example now. Concurrent validity. The table here shows the score gotten from a psychometric tool that was administered together with another psychometric tool, which will serve as gold standard to 30 respondents, determine the concurrent validity of the two.
We're not seeing, no.
Oh, is it that I didn't share it? Maybe, but I share it now.
It looks like.
Okay, wait, don't worry.
Some of us are seeing, no.
Okay, it's only Prof that didn't see it. Can you see it?
I can see your screen, no.
Yes, okay.
We are seeing.
I think that is concurrent validity.
Yes.
Yeah, but it will be hallucinatory if I don't see it.
You know that I remember one of my colleagues, he went for West Africa update. When he said that the West Africa in Ibadan update is public, they usually pull people from different faculty. That's what the way West Africa does its own. They pull people from different faculty. If they want to talk about all those hypertension, all those cardiovascular disease, non-communicable disease, they actually bring physician, they bring psychiatry, mental health, in public, they will bring psychiatry to come and give the lecture. So there was one Prof. Omigbodun, the wife of this man, Professor Omigbodun, a lady. So after he was teaching them, I said that they usually say that some of us say that we in psychiatry we are not normal. He has said that we are not normal. So somebody now said that, excuse me, ma, you are the only normal person among them. So sometimes, just like what Prof said, people don't understand people in the psychiatry also because what they are exposed to also, they are exposed to, the different set of people. Some also it affects their own thinking also, because your profession somehow affect your life. So that's just it. The way you think, your profession, like the way lawyer think, different from the way doctor think. Even among the doctors, the way we think differ based on the laboratory medicine and the physician. Every physician will think differently from a surgeon. They believe that surgeon just go in and remove and just come back. No, they are very aggressive. While physicians, they take their time. They say, lift your leg. Okay, let's just continue. Let's continue management. But surgeon, if surgeon you go to theater, he just go again. Say, look, this thing should be out. So that's just it. I think let's continue. So this one now, if you look at it, very simple. 2-1 and 2-2. We have 2-2. So we have administered. The score you are having here is the summary. It's when you have added every score together. This is the composite score for 2-1 and 2-2. So that's all. It's just for you to correlate. It's just for you to enter and correlate it. So in that case now, you have to administer the same two. These 2-2. So the same set of people. So one is the gold standard, one is the one. 2-1 is the one you are trying to validate. 2-2 is the gold standard. So I think somebody should run. So I don't want to be talking about, I just can use the correlation to calculate, and the answer, the correlation is 0.116. It's telling you that the correlation is weak, therefore the concurrent validity is poor. That shows that the validity of that 2 is not actually mentioning that it's very poor. Correlation of 0.12 or 16. Very poor. No, there's a weak correlation, very weak. It's not even up to 50. Even if it's 0.57, we say it's gambling. So for him to even say something is good, it should be greater than 0.5. Should be greater than halfway. So this one is a weak correlation. You cannot say this instrument is valid. I think is this psychometry?
Dr. Zalapo, sorry, before we run the data, I'm just thinking now, if you have two tests that you are comparing with the gold standard, how are you going to really handle it statistically? Because this is just tool one. Let's say there are two tools.
Yes.
And you want to compare with the gold standard. Are
Yeah,
you going to involve the correlation independently?
No, when you can when you know it's bivariate now, you correlate both of them to the something. You correlate both of them together. I think I have similar. You correlate both of you correlate the three. You correlate the three. You're going to see correlation between 2, 1 and the gold standard. Correlation between 2, 2 and the gold standard. Then correlation between 2, 1 and 2, 2. Yes, sir. If both of them they are strong correlation to the gold standard, both of them also they will be strong together. If one is strong to the gold standard, one is weak. So what will happen is that the other, both of them will not correlate very well. If one is strong to he correlate very well with the gold standard, and the other one does not correlate very well with the gold standard, both of them will not correlate very well together. But if both of them they correlate poorly to the gold standard, both of them will correlate very well. I don't know if you understand me now. It's possible now we have the third two, and the correlation with the gold standard is weak also. But both of them will correlate very well. They show that both of them are the same. They are the same poor. They are poor the same way.
That's interesting. I mean, that's very interesting.
I think there's somebody should read for us. I think it's that one that is psychometry. I don't know. I think it should be that one. Psychometry. Somebody who is reading for us, who is sharing. Or nobody to share. Should I call him? Let me call Iguilo. You know, I will call those people I can handle very well. I will not call the consultant. So I cannot call the consultant to be sharing and the prof. But let me call the people I know that at least they should be agile, more agile. Dr. Iguilo, what's happening now? Dr. Jane. Dr. Jane, what's happening? Oh, you are not there.
I'm here, sir. I'm here, sir.
Okay. Who will share?
I'm trying to join with my laptop, and they are saying my password, the password is not correct.
How can it be? Because it's the same password now. The way you have joined before. No. Which password? Okay, you join with you are joining with phone, right?
This one now is my phone, but I'm trying to join with laptop, and they are telling me that the password is not correct.
It's the same password now. It's not. Maybe you made mistake somewhere. Iguilo.
I'll type it again.
Maybe Iguilo is attending. Let me share my own. Don't worry. Maybe Iguilo is attending to our baby. So he's attending to our baby. No, women can be multitasking sometimes.
It's domestic affairs.
Yes. Yes, let me read from my own. I left phone. I'm trying to open my own. Yes, I did. I think that's it. I think I have it. Yes. Let me share. I've shared. Can you see it? Can everybody see it? Yeah.
Yes.
Okay.
Yes.
You can see quality of life scale
1 and 2.
And scale 1 and scale 2. I would say the scale 2 is the gold standard, and we are trying to correlate them. So it's just simple. You see, all about this validity now and reliability is for you to know what to do. The simple statistic you know that will be involved. It's just what of that is correlation. Analyze, correlate, bivariate. You now move both of them. So I don't know. Let me share my output. Can you see the output now? Can everybody?
Yes.
Yes, it's 0.116, the same thing.
116. That's what we got manually.
Yes. So, and that was we got done manually. So it's a weak correlation. And we already told that you don't bother yourself about the p-value. Even if the p-value is significant, just leave that. That's not the issue. If let's say the sample size is very large now, the p-value will be significant. Because small correlation when sample size is large, it gives significant p-value. Okay. Let's move forward. Any question on that? It's as simple as ABC, right?
It's concurrent, yeah.
Yes.
Agree with you.
Yeah.
Agree with you.
Why is this not moving? Yeah. Okay, I think so. The next one, I think there is. Okay, I think I put them together.
Okay, sorry, sir. Before you move on,
it's just output.
Okay, go on. Yes, go on. Jane.
Okay, please pardon my ignorance, or maybe if you had explained before I joined.
Okay.
Please forgive me. What is the practical application of this concurrent validity?
The practical application is, look at, for example, this one we just did now. We have, there's a tool before that they use to measure this, maybe quality of life. Maybe you say quality of life for people living with HIV, for example. And they now say it's a Manchester, the Manchester tool they use. And you now see another tool, maybe you develop here or they develop in another place. You want to validate it. You are not sure of this new one. You want to see, is it actually measuring quality of life? Since over the years, they have been using that Manchester stone that the name is actually measuring quality of life of people living with HIV. So it will make sense if you apply the same tool to people. If it does the same thing, the Manchester stone do, that shows that it's valid, it's measuring the thing. So the logic behind it is that you are missing the both of them, both the known one and the one that is new. So the same people. So here now we administer it to 30 people. So you record the score. They will score differently for each of them. When you aggregate the score, this is the score you see here. You now correlate. If the correlation is weak now, it's telling you, look, this one is not measuring the same thing as the Manchester. I already know the Manchester is measuring the quality of life of these people. If this one is not measuring the same, that shows that it's not measuring the quality of life. That's the interpretation. I don't know if I see you, the prof. I don't know if you understand now, Jane.
Yes, sir. Yes, sir. It's clearer now.
Yeah.
Thank you.
Prof was raising hand. Prof, sir.
Well, it's just to add to the fact that we consider both time, economy, and all that in the use of instruments.
Yes.
A typical example is in the quality of life we have been talking about. We have 360 questions, we have 100, and then we have 5.
Yes.
If you are able to validate 5 against 360, it is easier, it is more economical, and all that. So that's what we always do. We want something that will be simpler, that will take less time.
Okay, Jane, can you hear what the prof said now?
Yes, sir. Yes, sir.
Sometimes that is bringing the dimension to which is true. Sometimes these two, they not necessarily have the same number of items inside. Yes, Amina. Maybe the old one, maybe is measuring, but it has a lot of items. And people usually complain about, people, you are asking the question is too lengthy. Some people now go, okay, why not use this simpler one? But if the simpler one can do the same thing, the same result, but if we now find that I cannot do, you can see you have to stick to the old one also. Before you say you want to use that simple thing, something may be simple, is not measuring what it's supposed to measure. Do you get it now? So this tool now, the one we have just validated now, is poor. So that shows that you cannot say that it's measuring quality of life. Yes, the next one. The next one is predictive. A social support assessment tool was administered to respondents to predict their quality of life. The quality of life tool was later administered to the 30 respondents, determining the predictive validity of the social. What we are saying here, can you see this one now? You know, if many times the people give social support to improve quality of life of people, especially people living with HIV now. You know, we have to support group that they are giving them, you know, give them orientation. Some of them, they don't have work, they give them work. Some of them, they even give them money. You know, they are supporting them, and sometimes they do program for them because they believe that people do discriminate against them. Some of them, their families have abandoned them, they don't have, because they don't go to social setting, because they believe that those who know that they are HIV positive will be looking at them somehow. So they prefer meeting with their fellow HIV positive people when they go for recreation, social support. So you want to see if this social support, people that receive social support, because there is a tool which you can, social support may not necessarily mean that somebody, it has to be outside. Even within the family, people receive social support because there are some people, their family are very caring for them. They have, they visit them, they tell them, you know, they support them in many ways, even when they know that they have problems. So there is a tool that will look at if somebody has social support. You know, does your relative, do they go out with you? Did they support you? Did they greet you? No, they have some question that means social support. So if you score high in that question, so you are received social support very well. If you score low, you don't receive social support. So what is the essence of social support? It's not just social support, it's not just it's to improve the quality of life of these people. So to what extent will that social support predict quality of life? So those people that tend to receive high social support, do they have better quality of life? So is the social support predictive of quality of life? Yes, I mean, so that's a form of, so the issue now is that before you can even administer the social quality of life instrument, the person will have received social support and you will have administered that. It's later the person, you now see after a while if the person that receives social support have quality of life. So can social support predict quality of life? That's just an example. Though this one is an hypothetical example I brought out, but that's what it means, predictive validity. But most of the time you see that most examples people give about predictive is exam. It has to do with JAMB exam. Me, I don't have data on that. Just like what Dr. Balogun said. So I don't have data on exam and the result here. So I think this one is clear. Who will run for us now? Who will run this one? And this one has to do with social support. Okay, nobody is running. Let me run it. I think I have the data. I have the data set. Where is this note? Okay. Just a minute. I'm trying to look for the that's 16. Okay, it was trying to, yes, I think I've opened it. Let me share now. Can you see what I share? Can you see? If somebody can see, you can let me know, please.
Yes, we are seeing.
Yes, sir.
Yes, we are seeing.
Okay, yeah. You see, social support, you look at it, there are different scale now. Social support, look at the scale. Then this one, though these are aggregate, maybe the social support, I think the way they summarize their own is the average. There are many tools there. So let's see, it's still correlation. Can you see? All you want to see, those people that have higher social support score, they have higher quality of life score. Simple. So if you look at it, there's no much statistic, rigorous statistic when it comes to the quality of life. Wait. What is it showing me? Just a minute. I think it's showing me something. Analyze. Okay.
Oh, sorry, apologize.
I'm coming. Yes, I will stop sharing because the thing is the thing is not bringing. When I try to analyze, it's not bringing. It's bringing something for me. I'm just trying to. Sorry, let me close it because something is happening. Yeah, let me read it. Please, who can read? I don't know. My own, I'm reading the same thing. What is giving me is showing something funny. Who has that data? Social support
Okay,
and
let me
quality
check.
of life.
I think okay, let me check.
Social support and quality of life. Correlate. Are you trying to do that?
Okay, sir. So what? Yes, I've seen it. I'm trying to open it.
I think it's my SPSS.
I can share, sir.
Okay, share, sir. So okay. That's social support and quality of life, sir.
Okay, enable the sharing.
Okay. I think it's in my SPSS. Okay, I've enabled, sir.
Okay. Just a minute. Oh.
Mm-hmm.
Yeah.
Okay.
Yeah, I've done so.
Yeah, yes, I can.
Analyze.
Yes. By variate. Yes. My own was showing something else. I don't know. Yeah, just okay. Yes, you have to share the output, sir. You can start. Yes. Yeah. Can we see? What is the correlation? Can we see the correlation? 0.625. So if you look at this one, is support. It shows that it's a good one. At least it's better, fairly substantial, it's fairly good predictive validity. Moderately group predictive validity. At least 0.625 is able to predict that shows that the people that score high in social support, they also score high in the quality of life. While the people that score low in social support also score low in quality of life. Is it clear? Is it clear?
Yes, it is. It is.
Yes, sir.
Okay. Okay, you can stop sharing, sir. If you look at it, the same thing here in the calculation we make here, the same thing. It's the same thing, 0.625. I think you can see my slide. So now the SPSS output, we just got this, what we have there, the same thing. Then let's quickly discuss some, we just finished running concurrent and predictive validity now. When we talk about phase validity and content, that one, we don't do anything statistically about it. It's an expert. Each is expert you give the tool to validate for you. So to just look at it and say it's okay. Now, the concurrent and predictive, we are just showing an example. But when we get to diagnostic tech, we are going to go into another dimension of the concurrent criterion validity. I mean, in lecture, I will call you back. So we'll go to another dimension of criterion validity. But let's quickly look at construct. As we have said before, construct is the most difficult to conceptualize here. Now, what is this construct? Let's further discussion. Is it different opinions? Scientists put together from their own imagination. You get the picture. That's what Nonali, somebody said. People just think of something and coin it as it exists somewhere because you cannot see it. So a mini theory to explain the relationship among various behavior or attitude. Just people just bring us some theory and say, oh, this attitude is called this. If something behaves like that. In medicine now, okay, we talk about that. The name for pattern of covariation of trait or characteristic in individual. That's what Eaton said. Pattern of covariation of trait or characteristic in individual. So all those things, they are psychometric things. Similar to concept of syndrome in medicine. When they say something syndrome, they will not list a lot of symptoms. If they say anybody that have this syndrome, has this syndrome. So if you look at it, that thing does not actually exist. They just bring out some symptoms. But those symptoms also, some of them, you can find the symptoms in something else. Something else can cause each of those symptoms. But when you now have very different symptoms from different angles, and you can see it naturally, this is a syndrome. So it's more like a construct. It's just like I still imagine somebody that want to measure peripheral arterial disease using questionnaire. To me, that one is a syndrome. It's a construct. How do you use questionnaire to? I know that yes, you can. When you use you ask question. You ask some questions. You do some physical examination. you can dictate something, but when you just ask question on peripheral arterial disease, the extent to which operational variable used to observe correlation in and between construct can be interpreted in terms of theoretical construct. Those are different explanations that people give. We also say the degree to which a measure satisfies theoretical prediction about construct across a range of theories and with a range of modality of measurement. And how well does your measure fit into nomological network? The nomological network is just a network of that just link some concepts that are related. Look at it. In the absence of a gold standard or absolute point of reference, attempt to nail down construct through triangulation, fitting into a network of related construct and measure. This is an example of nomological construct or network. Is an example of using nomological network is an example of external construct validity. Look at it, anxiety, depression, they are related. Prof, we can tell us much about it. Then, before you can say somebody is anxiety, oh, is he nervous? How do you diagnose anxiety? Is he nervous? Is he stable? Maybe you cannot sleep. Then, depression. Sleep also. Can you see? The anxiety now and depression, somehow, they share sleep disorder together. Is somebody sad? Is he guilty or something? So those people that diagnose depression, those are the sort of question they ask. They may not see any biological something. The blood sugar is okay, everything is okay. But they ask some question and then I say this person is bipolar depression. That is a form of nomological network. Sometimes when you want to validate, you just, okay, if you feel that anxiety and depression, somebody that have anxiety, if this question, you want to use a particular tool to diagnose anxiety, you can bring a tool. If somebody has a tool that diagnoses depression, you may apply the tool too. If both of them they should, so to start extent, they should correlate. If they correlate, you know that, well, most of the people think that cause depression also cause anxiety. But if they don't correlate at all, and the other two have been validated to be good for depression, that shows that it's not likely that this tool that is measuring anxiety is actually measuring anxiety. That's the way of using. Can you see? It's so fluid. So we talk about the type of, I've explained the type of this construct validity, involve relationship between indicator, measure, and construct. Then external construct validity, also called monological network validity, involve relationship between construct and other construct or variables. So this this one we explain under construct validity that we talk about convergence, discriminant, known group. They are example of internal construct validity. While the nomological is the one that is external construct. It's different from external validity and internal validity. Quite different. But if you have to say internal construct validity. So the discriminant, degree to which indicator or measure are associated with indicator of the same construct and not with indicator of different construct. That is, like now, if you have a tool that is trying to measure, let's say, depression now, something else that is not depression, that is opposite of it doesn't have anything to do with depression. It's not related to depression. If you now administer the two, the same two, they should not correlate. If you assign a two that is measure you want to validate the two that measure depression, I now have a two that is measuring something that is not related to the depression. If you do it correlated, they should not correlate. That's discriminant. But if it is a tool that is anxiety, it should correlate with it. That would be convergence. It's the degree to which indicator measure are associated with other indicator of the same cause. Okay, or you have another two. Let's do like this. You have another two. These two also measure depression. It may not actually be a gold standard. It may not be better. It measures the depression also. You now correlate the two. If they correlate very well, that's convergent. But if you bring another two that is measuring another thing, they should not correlate. So that is discriminant and convergent. Then non-group, a group with the already established attribute of the outcome of consult is compared with a group in which the attribute is not yet established. In this case now, for example, yeah, we have an example like that here. This supported group, not supported group. This not supported group, then we have other supported group. You know, we are trying to see if these two measure social support. You have a group somewhere that receives their social support. You have another, maybe you just want to know if this thing measures social support. And you have a group, and you have another group that have received social support. If you apply the same tool to this different group in different contexts, if the score are similar, that should yes, is measuring social support. That is non-group. So how do we establish this control validity? It's most difficult. Correlation of score with the score of other similar constructs, which we have just said. Comparison of score with score of group with known validity, which is the known group. Then factor analysis. Factor analysis is another statistical method. That one is looking at all those things that the item you put there, are they actually measuring those at the point? Though the way it works as if it's similarly to internal consistency. Are they actually looking at the same thing, pointing at the same thing? That's what factor analysis does. So that one now, we cannot do that one here because it's a training on its own, factor analysis. So that factor, that's not the only thing you use factor analysis to do. Even designing most of this psychometric tool is factor analysis you use to know you add a confirmatory and exploratory factor analysis. Now, we have ample example of correlation here. So what the example I now gave here is to do the non-group validity. Now we have two groups here, or three groups here. We have people that receive social support. We have people that are not supported. We have people that are another supported group, different group in different contexts. So we have a tool that measures social support. And when we administer the tool to them, these are the score. Now you cannot, so we cannot do correlation. Who can tell me why we cannot do correlation in this context? Because it's a workshop now, let's stimulate our brain. So that I can give opportunity to talk. Why should we not? Here we cannot do correlation in this context. Why? If you quickly spot, you will know the reason we cannot use correlation in this context.
I think there are three groups.
And even if there are two, let's say even there are two of them here. It can be two, it can be three. It's not because of three. You can do even with three.
I think one looks like a categorical
science. What about the science?
Science as how?
Negative. Okay. Well, it doesn't matter.
One is categorical. I think so.
No, there are three.
But Prof, you are the one that is close to this because he says because there are three groups. It's not because it can be two groups, it can be four groups. The issue, okay, the issue here is because they are independent groups now, because this data is not from the same, this three group of data is not from the same person. If you remember all this one we have been doing, you administer to the same group. It's either you do test retest, or you do parallel form, the same different two administer to the same group, or even when you say you are doing concurrent validity, it's the same. You are applying the two methods to the same people. You can only do correlation when the two set of data is from the same group. I don't know if you understand me now. If you take measurement, these two measurement or three measurement from the same group, you cannot. That's the only time you can correlate the score. This one now, they are different groups. They can two different groups or three different groups or four different groups. I don't know if you understand that. Do you understand?
If you go back to the original source,
And you go back to the original source.
If you go to the original source, I would
look at the original source now. We have this quality of life. These people you have, if you even look at them now, say, I even number them serially 1 to 30, 31 to 60, 61 to 90. There are 90 subjects here. Yes, I mean 90 subjects. The first 30 are the supported group, the second 30 not supported group, the third 30 are other supported group for another setting. Can you see now? So it's the same two. Can you see now? You administer to them. It's the same two. Unlike this other one we have done. Look at this other example we have done here. Look at this. If you see the subject 1 to 30, the only 30 people, where we administer different two, social support scale, then quality of life scale. Can you see now? The same group, we just administer two different two to them. That's why you can correlate. Because these two scores, two sets of scores, they are from the same set of people. Look at this one. That look at 2-1 and 2-2. 2-2 is gold standard. Look at 1 to 30. You administer 2-1, 2-2 to the same set of people. That's why you correlate. So even all the one we did under look at it. But this one is yeah, the same thing. Even this one, the score, the questionnaire when we do internal consistency, of course, it's the same to anyway, the same to just 4 questions. Which one is test retest I'm going to? If you look at this one, parallel form, look at the subject 1 to 10, test A, test B. To this is two different to the same people. Look at test retest. I think this is test retest. First visit, second visit, the same group. Can you see? In all the situation where he did correlation, it's the same group of people. Either you administer the same test 2 times, or you administer 2 different tests to them. But the data is on the same people. But this one we are dealing with now, there are 3 groups involved, the same 2. So you cannot do correlation. Does it make sense now? I want a response, please. Because this one is
Dr. Dolapo, yes. Are you trying to say that in research, if you have 2 or 3 independent groups and you are trying to look at maybe a common endpoint, that you cannot do correlation between the two independents.
You don't do correlation between groups. Yes, I'm not. You only do correlation between two variables in the same group.
Yes.
You understand now? So if you not that we cannot do correlation if you have three groups, you can do correlation if what you are correlating are two variables or two variables that you measure across all of them also. You understand now? If let's say we take this measurement 2 times now, we can do the correlation for maybe we have 2 we administer, or these 2 times. You can do the correlation for each group or even lump all of them together to the correlation. But what we are talking here in this data set now is only 1, 2, quality of life, only 1. And we now have 3 groups of people. You don't correlate between groups.
Okay.
You correlate between 2 variables. Is it clearer?
Okay, I want to just ask this question. Let's say I want to do a study on anxiety scores. I'm comparing undergraduate and postgraduate and maybe secondary school students, 3 groups. Yeah. Then I administer the scores. And are you saying that we cannot find correlation between the scores in secondary and maybe the postgraduate or undergraduate students? Is that what you are trying to say, sir?
Yeah, you cannot. Yes, you cannot. Because the group, if you remember, correlation is as the degree of association between 2 quantitative. Yes, I'm not. Even when you use a categorical like ordinal, you have to give a score. So in that case now, you have a score, anxiety score. Yes, it's a variable. But the other variable that is serving as group now is the category. Yes, I'm not. Yeah. So what you can do, you do t-test if there are 2 groups, or do ANOVA if there are 3 groups. I don't know if you understand me now. So you cannot do the correlation. You can only do correlation if there is another quantitative variable there. You can do correlation between the anxiety score and another thing, maybe and their age and anything. You understand me now? And when you are doing it, you can do it in that case, you can do it separately for each group, or you can lump all of them together and just do it for the whole people. The correlation between age and anxiety. Because age and example that are different variables, and all of them, each of them have their age and each of them have their anxiety. I don't know if you understand me now.
Yeah, thanks.
So in this setting now, you cannot do correlation. So the validity we want to do here is non-group validity. That is, you already know that, look, supported group somewhere, they have that attribute. Another supported group have attributes. So you already know that that supported is a supported group, and here you have another supported group. They are similar, then in different setting. And if you apply the 2, and now see that you are trying to measure social support, and now see that both of them score similar, it may be pointing, it doesn't 100%, but it may be pointing out, oh, this one is actually measuring the social support. And when you now compare with not supported, you now see different. I don't know if you understand me now. So that is what we just did here. Look at it. What we did here is just to calculate their mean, everything, do t-test for supported versus not supported group. So what do you expect? No, other supported, the first one, supported versus other supported group. What do you expect? Do you expect any difference?
Yeah, we expect the mean of the supported to be higher.
No, supported versus other supported group. It should be similar because other supported group. Yeah, and that is why. Yeah, that's why if you look at the t-test, there's no significant difference. The p-value is less than 0.05. Look at the t-test. Then conclusion, no significant difference. Therefore, there is a constant validity. Supported versus not supported group.
Okay.
You expect a difference. Then also supported versus not supported group. Can you see a difference?
Okay,
look at the t. The p-value, the t is very high, and the p-value is less than 0.05. There's a signal difference, therefore there's a control validity. Does it make sense? So you will see that there's no one statistical method that say, oh, this is construct statistic. No. Is the logic now use is a reasonable statistic to now do it. So this is the t-test and run the same thing. You get the same thing if you calculate with her. So somebody should, let's run it. It's a part of exercise. Before we move forward to the next,
Dr. Delapo.
Yes,
Dr.
sir.
Delapo.
Yes, sir. Go on, sir.
Dr. Delapo.
I'm listening.
So the two conclusions are the same. The two conclusions are the same.
Yes,
I said the two conclusions are the same.
Yes. Yeah, because yes, they are saying the same thing. The first one,
the one, no significant difference. There is constant validity.
Yes, because you are comparing supported and other supported. It's similar group. It's just like I don't know if you understand me now. You are comparing people that receive social support in Nigeria with people that receive social support in Ghana.
At least
you should not expect their score to be similar. I don't know if you understand me. Both of them should score high. So if they score high, it means that somebody. Dr. Balogun, are you listening now? Can you hear me? Hello? Doctor, hear me? But your this is not clear. It's your voice. That's why your network is not stable here. I think you have gotten it now.
I hear you.
Yes.
I hear you very well.
Yeah. So because the first one is similar group, so you don't expect their score to be the same, so to be different. So when you compare t-tests, there should not be significant difference in their score. Even though you can observe different, but it should not be statistically significant. Then when you now compare supported with not supported, you expect statistically significant. So that's why the conclusion is the same thing. You are trying to tell the same thing in different way. I don't know if you understand me now. Just like you want to you want to prove that a school is good. You understand me now? A school is good. You two students from the same school, they score very high. They just score very high. So you can see both of them are sharp. Now bring another student from another school that you want to prove that is no good. That was no good. You see, can you see what I say? Can you see? Can you see what I say? So the difference is clear. Then when you bring another person from the other same school, the good like the other person, can you see what I say? It's the same conclusion. So you are trying to test the same thing in two different ways. I think it's very clear now. I think it's very clear.
Yes, it is.
Yes.
Thank you, sir.
Any question? Yes. Any question?
Yes, it is. It is.
Yes. So don't worry. By the time
I wanted to just confirm.
Okay, confirm. Go on. Go on.
Because I noticed that with the t-test, it made sense because I know that for quality of life, it usually comes in scores. So what this means is that depending on what you're trying to make value, you can use chi-square, can use ANOVA.
Exactly. You are right. Can use chi-square.
I know that.
If it is something that you summarize in proportional, you don't expect if they are similar, they should have the same percentage, so the chi-square will not be significant if they are similar group. For the group that is different group, you expect statistical significant difference in the chi-square. So if you look at it, it depends on the type of variable you are measuring. So that was why I said the validity, reliability is your understanding of the concept. So when you understand, you choose the appropriate statistic based on the setting. So I think we have finished discussing that aspect now. So we go to, we start discussing diagnosis tests because tomorrow will not be enough to finish it if we don't start it today. So any question in this one we have done? Any question?
We didn't come. We didn't finish.
Somebody, Dr. Yemi, you are making noise here.
Oh, okay. Sorry.
You moved here. Yeah. So you can see the slide now. Let's start the discussion on diagnostic tests. You know, many diagnostic test results are given in form of continuous variable, such as, but some also are in categorical variable, not all of them, but like something like fasting blood sugar, fasting blood glucose, hemoglobin concentration, systolic or diastolic blood pressure. They are given in form of continuous variable. There are some that are already in categorical, like if you do malaria parasite, we have the quantitative aspect and quantitative aspect. Malaria parasite present, absent, positive, negative. Then some can, when it is possible, you can quantify the parasite load. But most of the time, it's the positive and negative aspect we want to know. Just like with pap smear also, even though the pap smear also can have a grade, but you have like most of these cancer something, diagnosed cancer, you not grade, differentiated, non-differentiated, just grade it in form of, but there are many laboratory tests that are in quantitative form that you give. Even some that you look as if something like PCV, where hemoglobin concentration in the PCV there, expressed as percentage, is quantitative. Even sometimes when they even give white blood cell count that come in form of percentage, but is recorded in form of figure, in figure form. So we see that somehow somebody is making noise. Somehow the test you are running, they will give you some figure. Apart from the one that can tell you categorically is present, not present, no problem. But those ones that give you figure, at what level you say somebody have the attribute? Because as clinician, you want to know who to treat, who not to treat. At what level you make a decision. Like some diagnostic results, like for systolic hypertension now, you see blood pressure above certain level. Above certain level. Whereas in some, something below certain level, like anemia, hemoglobin concentration below certain level. So how best cut off? How will you know that, okay, this person, the result given require treatment or it doesn't require treatment? That's what all about what we want to look at in diagnostic test. So the first you want to look at is the reference interval. So what brought is this problem of knowing who to treat and who not to treat that brought normal range, reference range, and many other terminologies. So the reference interval is otherwise known as reference range or normal range, though some people kick against normal range. No, before you were hearing normal range, but no, it's normal, it's a reference range. But to me, for many people also, it means the same thing. It means the range at which, okay, this person may not require treatment. Then the range outside which you think somebody may require treatment. Though, when we say normal range references, sometimes in the population, you still have some people that have abnormal value, but they don't have problem. But when somebody now comes to you in the hospital or you are treating somebody, that one will guide you whether to treat or not to treat. After all, you as doctor, clinician, It's people that come to you that you attend to. That's why sometimes I just laugh. Many pastors, when they preach, they attack doctors. They say doctors are liars. But the issue there is that it's people that come to doctor. So if people come to you, have problem. I mean, your own way is scientific way. Even if you are a spiritualist, you are a Christian, you may reflect, but the training you receive is to use scientific way to treat. If it is an herbalist, they use their own way also. Their own. What work with them is that, and spiritualists is when you first of all come, they tell you what you have, so that you can believe that yes, this person know work. They can tell you something about them. They tell you something about you. By the time they're able to tell you something about you, that the one that non person will not know, yes, you now have confidence in them. But doctor, you don't work like that. So you use the scientific way. The concept introduced by Grasbeck and Salis in 1969 was this reference interval. It was in response to growing awareness expressed with great clarity in the reflective paper from Snyder that the concept of normal range as then conceived was flawed. It now brought about reference interval. Current practice at the time was to compare patient result with an ill-defined or at least inconsistently defined range of value called the normal range. Why many people kick against the concept of normal range there was by that time people just use convenient way. They just take blood of medical students, people that are available. The lab people, students, and they are available in the workers. And I believe that since they are not sick, they should be representative of the normal range in the population. But it's wrong. It's actually wrong because you know that there are many things that make the health workers to be quite different. Health workers are not representative of the population. In fact, most average health worker is a middle class person. You may have few that are high, upper class, the average middle class. So, but most of the people that are sick, that are even coming, that are in the population, they are lower class people. Because somehow, socioeconomic status, the class, and many social issues contribute to health. If somebody is going to be sick or whatever. So the people, both the medical students and people, health workers, are not representative of the society, of the population. They are far from representing the population. So that was what they were doing by that time. They just collect from the vicinity, people that are not sick, and I say this is a normal population. And that was why the definition was ill-defined. So normally it was derived from all ill-defined population of supposedly normal, meaning healthy individual, then. So how do you determine the reference interval? Why they talk about reference interval is that the value, the range of value you make reference to for you to take decision about who to treat and not to treat. So they just, though if you look at it, to some people it may mean the same thing, normally reference interval, reference range. So there was in this National Committee of Clinical Laboratory Standard, now called Clinical and Laboratory Standard Institute, it defined a scheme for determination of reference interval as follows. The reference individual comprising a reference population from which is selected, a reference sample group on which determine values on which is observed, a reference distribution from which are calculated reference limit and defined. This one just there for academic purpose because it turns twisting. The same thing also can be put in flow chart. Can you see? The same thing I just read now. Reference individual comprise a reference population from which is selected. Let me put something so that you can see. Selected a reference sample group on which a are determined, reference value on which is observed, a reference distribution from which is calculated, reference limit that define a reference interval. What did I just try to say? That they select some people in the population. Those people they selected to determine reference interval. They call them reference individuals. But these people are selected from a reference population, from a population of people. So it's a reference population, but not all of them were selected. They selected some people from the population. These people selected are reference individual. So the sample taken is reference sample. So from it, the value they got from the sample are reference values. The distribution of the values, reference distribution. From the distribution, you now calculate a limit. The way you say, okay, above this limit is extremely high. Below this limit is extremely low. That is reference limit. From that is the reference interval. And that is why when you, the result of even when you buy a diagnostic equipment, they also give you, the manufacturer give you the reference value. So they've used it in trying to validate the instrument. After they manufacture it, they try to validate the instrument. They use a particular population to validate, to now bring a reference value. They believe that, okay, within this value, it's okay. Beyond this value, it may be, it's just an alert for you as clinician. Now, so I will not bother. Is all this? There is this International Federation of Clinical Chemistry and Laboratory Medicine. Define all these reference, individual reference. I will not bother you with it. I just, if by the time you get the slide, you can. I will not bother with that. How do you estimate the reference interval? There are two methods, even although there are three, that the other one, just, there are major two, the normal distribution method and non-parametric percentile method. There is this other one, this is optional method, is given by America, is not this institute? Yes. It's given by this Laboratory Standard Institute. They have a protocol, stringent protocol, but the stringent protocol should boil down to using non-parametric percentile method. And that is why the two we are discussing here, the normal distribution and non-parametric percentile method. The International Federation of Clinical Chemistry recommended method for estimating reference interval is the non-parametric method. That essentially involves is simply including the lowest and the highest 2.5 of reference value. So in this slide, you understand it better. So if you, the options for determining the interval, you can select, you can decide to say, okay, when you take value from the population, you take reference individual from reference population, you measure the variables, the variable you want to measure. You can decide to take 90% as the reference interval, or the middle 90%, or middle 95%. Or it may not be middle anyway, 90%, 95, 99, 99.9, 99.99. But the method that is being used by most people is 95%. That's why I highlighted blue. Now, the 90, 95, or let's say 95%, you are taking maybe both two-sided or one-sided. You can use double-sided when there's both a lower and upper limit normality. Both low and high value are suspicious. You know, there are some tests that the low value are not so important, just the high value. There are some tests the high value are not is the low value. But there are some that both the low and high. So it depends. So that's where the clinical experience comes in also, the clinical judgment. So if it is for double-sided, when both upper and lower value, like sugar now, we have hypoglycemia, we have hyperglycemia. For even PCV, we have anemia, we have polycythemia. I think for both, whichever side, dangerous. Blood pressure, I think the same thing also. You have low and high, extremely low and high. But there are some other things that people may not bother about the high, there are some people may not bother about the low. So left-sided, when there is only a lower limit of normality and no upper limit of normality, only low value are suspicious. So in that case, you push the 95% on one side. So you look at the upper 95%. So the lower 5% suspicious. If it is right-sided, when there's only an upper limit of normality and no lower limit of normality, only high value are suspicious. You push the 95%, so the other one will be 5%. Right. But if it is two-sided, so the 95% will be in the middle, so you're going to have 2.5%, 2.5%. See, this thing is not difficult to understand. If when we talk about two-tail, the other time we have talked about two-tail, one-tail. So this two-sided is like two-tail, while the other one like one-tail. Now, estimating reference interval, parametric method, which is the normal distribution method. If you are using normal distribution method, simple, pictorial. If you do your this, you normally it is assumed in normal distribution method, it is assumed that that attribute follow normal distribution in the normal, that is in the population of people. Yes, Prof. You raise hand. Prof. You raise hand.
No, not me. Maybe another one.
Somebody raise hand.
Okay, doctor. I think it was a mistake. Yeah, I just pressed something. I wasn't deliberate.
Okay, no problem. Yeah. So you see now the normal distribution, which is the parametric method. You know, I've already talked about parametric method, which is normal distribution method, and non-parametric percentile method. So this is normal. Once you carry out the assessment, laboratory test, or whatever. If you plot it, so this one now, if you want to do validation and you want to validate a particular test, or any test, want to know the normal range or whatever. It's used to take sample, when you take your measurement for that sample, reference population and reference individual, reference population distribution, as they have said. If it is one that follow normal distribution, yes, you can use the this method. When you plot it, you calculate the mean plus or minus 1.96 standard deviation. You calculate the mean and the standard deviation. 1.96. If you remember, the middle 1.9 plus or minus 1 is the one that captures 95%. Though many people use 2 standard deviation because they just approximate it. But you know that the 2 standard deviation is 95.45. Is 95.45%. The two between -2 and +2 is 95, is the middle 95.45. It's not actually 95, but the 95 corresponds to 1.96. So using 2 is an approximation. The difference will not be much anyway. But the right thing is plus or 2 standard deviation. So just for you to run your analysis mean standard deviation just multiply 1.96 standard deviation. You multiply the standard deviation by 1.96. When you multiply it, that will be 1.96 standard deviation. You remove it from the mean, you add it to the mean. What you get will be the normal range. That is the reference range. That is the normal distribution method, parametric method. The estimation of reference interval non-parametric method, that is non-parametric, that is the one they call non-parametric percentile. Why they call it percentile? You see, because many it's not all test, the variable you are measuring, the test, stability test or any test that follow normal distribution. And even if it naturally follow normal distribution in your own data set, it may not follow. It may not follow they may not follow normal distribution. So that was why this is the method recommended by International Federation of Clinical Chemistry, the non-parametric percentile method. What they just do is that when you run the analysis, you look at the, thank God it will give you cumulative frequency. The first 2.5, if it is the first 2.5 value is considered to be extremely low. The last 2.5% that is low, the highest one, highest 2.5 is considered to be high. So the range is between the 2.5 to 97.5. Between 2.5 to 97.5. That is the reference rate. Now, what I did, I don't think I shared this one with you. I will run it. I will send the data set to you. I will send the data set to you. I will send it to you now. Since nobody is interested in running, so otherwise,
don't assume so.
I should not assume so. Okay, I will send it to you now. Let me explain.
I'm interested.
Yes. As part of the effort to determine reference interval, because as I was saying, it was later. Many times when you are preparing for this thing, try to gather data that best explain. You can have many data sets, but it's not everyone that explain what you are, that give the knowledge very well. Just like what we discussed about teaching a particular method, the impact on teaching. Sometimes it's not every time I say that I have impact of teaching. If you use to demonstrate, people may be confused. So you are looking for the one that lay the explaining. And while you are trying to gather, someone like Dr. Ikobo want to get to know, lay his hand on many things before you come. Begin to trouble you, send the module, send the data file, send it. So that was why I had to quickly send the other one before I was able to compile this one. I will send. As part of the effort to determine the reference interval, the value of total serum protein, PCVI, alkaline phosphatases were determined for 119 neonates. The table below shows the reference interval as determined by both normal distribution Gaussian method and non-parametric percentile method. So what I just did was, okay, I run the mean. So all this is not a straightforward thing that I just press computer, it will not give you a result like that too. Of course, it will give you the mean and standard deviation. It's you that will now do the rest. It will run the frequency for you. It's you that will do the rest. Though it is easy to bring it out as we run it now. So you can see the mean for each of these total serum protein, PCV, alkaline phosphatase. This is the standard deviation. Then his mistake is 1.96 I use. It's 1.96. I just put 2 here. 1.96 standard deviation. Then you now use to calculate the lower. When you remove it from the mean, it gives you the first lower. If you add it to the mean, it gives you the upper. But this one, non-parametric percentile method, when you run the frequency, you mark the 2.5, the value that coincides with 2.5, you mark the value that coincides with 97.5, you put it. But if you look at it very well, look at this table very well, you will see that even the value, they are very close, not the same. Look at it, 4.6 to 7.66. This one is 5 to 8. Can you see? Through the distribution method is 4.6064 to 7.66. Look at the non-parametric percentile method is 5 to 8. Look at this, it's 35.9 to 57.5. This is 30, this is where the difference on 38 to 59. This one is 15.1 to 90.9. This one 24 to 98. If you look at it, this first one is very close. The value is very close. But this one, and but despite the fact, the reason is very simple. Why? If you look at it, if you go and explore it now, this one is more normally distributed. The distribution is normal, more normally distributed than the other one. They are skewed. So when they are skewed, you cannot, and if they are skewed, you of course you know that the one for this using standard deviation is not as accurate. It will not be as accurate as the one you use the percentile. That's why when something is skewed, people prefer you talking about the median, because the mean is extremely affected by the skewness, by outlier. So that was why, if it is skewed, the normal non-parametric method is better. If it is normally distributed, the value will be the same, almost the same. So that is why the International Federation now opted for the non-parametric percentile method to check the normal rate. And especially when you have live data, it's good if you want to do it to have live data. When you have live data, perfect, it will be okay. You'll be able to get a sample, the last sample, a sample that is representative of the population. So let me quickly look at, is there any question before so that we run it? Let me check the data so that we run it.
Yeah, Dr. Olapo.
Yes, sir.
I sometimes find some reference ranges not fitting exactly into what is being described now.
Okay.
Some reference ranges may be, let me say, between 45 and 250. You understand? They are unusually very wide. Does it mean it was like in such scenario, they use the non-parametric method to determine the reference?
I say that is the International Federation of Clinical Chemistry recommend that non-parametric method. That is why did you say that? Anything can be like that. See, there are some things that are like that. Yes, I mean now. Because so another thing, that is one of the things we recommend, is that it's good to do the reference rate for your environment yourself. In fact, it's been recommended, if you read many impact journals, they recommend that forget about, don't just rely solely on the manufacturers, this thing they give. You know, many people, they will flexible, especially these people in laboratory. They are proud to say, oh, they just bought the analyzer. And that's it. This is from Germany. This is the reference value, as if it's the one inside your blood. They collected the data. They use that into, you know, they use that thing for many people, and they collected sample from many people in their own environment and did it. And they are forgetting that these people are business people. The engineer that manufactures, is money they want to make, and by the time they just give you. In fact, sometimes the study they do, all these people that manufacture drug manufacturer, the quality of the study they do is questionable. There are ethical issues. Because when you manufacture something, you put in much money and you want to lose. Like drug now. No, after the surgery, they know that after all, there's no drug that doesn't have a side effect. So even sometimes they dodge the result. They try to dodge the result somehow. No, they want the result to be the way they want it. So when they bring reference value for you, it's good for you to now collect data. No, I read an article, was it not yesterday? I talk about this creatinine kinase. They say that the reference rate, reference value given by manufacturer They discovered this white man article. They discovered that 9% of the European women, their value, they mark people 9% that are normal to be abnormal. You see, when you now go to other, maybe other is Asian, about 17, you see, black, they mark about 42 women to be abnormal, that are normal. They say 72%, 42% of women or black women, 72% of black men were marked to be abnormal. Look at, for example, when they are talking of the reference they use for BMI, you yourself you know that it's not realistic. You now, me, Dr. Balogu, I know that you are not obese, but with that reference, they will say you are obese. You agree with me? With that reference, you are still obese until you slim down to kill yourself. So when they brought some, you know, look like India. No, normally they are slim. They will do something in India and come and give it to us here. So somebody, so those are the things. So we need to carry, you know, when you bring the material, the equipment, you collect data in your own center and do the validation and get the reference value. Though we know that it's very costly, sometimes it's not all the center can do that. Before you can come out with a DC, you may have to do multi-center because you may not be able to have enough data in that center. You may have to do multi-center study. And for you to do that, it requires a lot of time and expenses. So there is something that is worth it in our environment. So let me quickly check the. I will not be given any word. Let me check the. Bring out the file. Reference Tabaya. Oh, can I even wait? Let me even just do it now because so that you can follow it. Because as I'm running it, some people like running that thing. My internet is here. Yeah, so that let me just send to us. Or maybe what I will do, let me send to somebody that will just send. I will do it. Say, Doctor. Okay, let me just. If I can follow, yes, the mail I sent before. Let me check the mail I sent before. I can use it. The trail of mail I sent before. Yes. 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 Just 1 minute, I will attach it now and send. Zoom. It's only Jane I didn't copy in that something. I've put the something there now. So I forwarded it. Anybody I want to open it, can open it. So let me just read. Wow. Okay, hi. Where? Let me share. I forwarded the mail. Please, you know what? I think what I didn't do something I wanted to do. I wanted to delete other variable to only remain only that one, only those one I use. But I forgot. I just said, please It's somebody's project that is do the person that passed it. I just try to extract those variables from it. So you may have to delete because you have to delete everything. I wanted to, I forgot. I thought I have deleted it. My own was to delete all those other things that I'm not using because it's something somebody's project. It's not good to share it with people.
Oscar, do we delete that particular one?
That's what I was supposed to do. Like now, yes, I wanted to delete. I didn't know that I didn't delete it before. I thought I had deleted.
What I can do, because if I can delete it, then maybe you can.
Yeah, you can delete. You can delete it. Like now, all you need to do, what we are looking for is just somewhere. If you look at the number, the row 62, 63. If we go to the variable view, row 62, 63, 64. Those are the one I will need. Those are the one. Every other thing deleted out.
That's what I was saying. Yes, you can just do all the deletions. Then
yes, that's what I'm actually doing. You can see it now. So, was right. Just delete all the, that's what I'm doing now. Just select all those other something. I thought I deleted it. No, that insert. Clear variable, yes. Delete all those things. Then you don't need to delete what? Okay, yeah, there's an issue also. So don't worry. What I will do, that I will send to you, self, because it's not because I only did for the unit, the cohort. I only use the value for. We have two groups. It's a cohort study. It's the control I now use. The control. So apart from the variable, also even the data set. Clear. Apart from the variable, even this data set. So, Dr. Ikobo, Dr. Ikobo, sir, you see what I'm doing now? All those other things I'm doing, you are seeing it. I'm trying to remove all those variables I don't need. I just select them and just right click and say clear. All those variables, I don't need them. So it's only those three variables I need for that thing. And it's only that three variables I want to share with people. Because it will not be fair for somebody. I myself, I cannot even do anything with their the old data without, unless you even get permission. Okay. The person, if I tell you the story about this person's project, you will laugh because it was a dime minute something they brought to me. The work was upside down. We salvaged it and the person went to get distinction. Yes, I think I have deleted. I just deleted the serial number and the group. So the group also is the grouping. Okay, I see. Okay, yesterday. What's up? Ascending. Yeah. Okay, no. Yes. Yes. So also, I don't need the, though I can, the control group I'm using. Because we had cohort was 41, control was the 119. I'm trying to delete the control, the cohort out. It's only the control I actually need. Almost true now. Yes, I should have 119 now. Yes, correct. We'll be doing the numbering later. Okay, I think we can just run it now. Maybe I will send this one. I will send this one. Just neglect the other one. I will send this one to you. Neglect the other one. Please. Neglect the other one. I'll send. So that because while I'm doing it. So neglect the other one. Yeah, so we run it now. This thing slow. Okay, well, the thing is just, so I don't know if there's any question on what we have done. Oh, proceed. Why is this thing hanging?
Somebody sent a text to ask the question.
Okay, that's great. Let me check. Let me check it. Okay. Some school of thought fought the use of correlation or validation. Yes, I'm reading the question. Some school of thought fought the use of correlation for validation. Instead, the Bland-Hartman approach is said to be superior. Can we briefly talk about it tomorrow? Almost 9. Okay. Yes, the Bland-Hartman approach you are talking about is for agreement. It's for agreement, and you see that it's only useful in certain aspects. We'll talk about it tomorrow. We'll talk about it. It's only useful in certain aspects. So, though somebody can say that, well, the sort you get from it may be okay, but it's only useful in just small aspects. There's many situations you cannot use it. It's just one of those innovations, just like the way current kappa came with this thing. So, but there's no, it's not all the situation you can use current kappa. So that's just it. And when it comes to validation, you know, a lot of strides have been made when it comes to reliability, but validity, leave it. We will see tomorrow. We'll discuss it anyway. Because somebody have analyzed somebody project for somebody else. So use that Atman you are talking of, pediatrician in a national hospital. So immediately he brought the work. I thought that this work is not good from the design was faulty from the beginning. Of course, he went to fail. Later, we had to palette eventually before he now stayed through. So we discuss it tomorrow, sir. Okay. Yes. So I like, yes. I want to resend it to us now for anybody that want to open it so that because I know that many people, because as we are running here, a lot of people they try to run it on their computer. It is then they ask questions. So because I want people to follow what I'm doing here. And once we just finish this one, we will close for today. At least we have touched. So tomorrow we go directly to other sensitivity issue. Okay. again. So I'll send a new one. Please neglect the first one. Don't even open it at all. Neglect the first one. So some people are sending. Please, can we do a revision of that non-primary counterpart tomorrow and the reference tomorrow? I will also watch the video. I did not understand the reference part. Thank you. Okay, no problem. We'll do the quick revision because if we start talking much now, or should we even stop here so that when we do the revision, since I've sent it to you. Let's stop here. So I'll send it to you now. Just open and you can, what I've done, you can try and do it. So just start with this last one and run it. Okay. So now we stop here. Thank you. So any other comment? Any comment? Let me stop here.